Our next session is on the evolving landscape of metastatic hormone-sensitive disease, in essence, broadening the discussion we just had about radioligand. I'm going to have the panel introduce themselves, and Chuck, let's start with you.
Hi, I'm Chuck Ryan. I'm from Memorial Sloan Kettering Cancer Center, and I'm a medical oncologist.
Neeraj Agarwal, medical oncologist, Huntsman Cancer Institute.
I'm Michael Morris, medical oncologist from Memorial Sloan Kettering Cancer Center.
Chris Sweeney, University of Adelaide, without a microphone.
Tanya Dorff from City of Hope in California.
Apologies to Mike for not having his picture. I'm not sure what happened. And note, Neeraj is running for the ASCO nominating committee. He's not allowed to self-promote, but if you're so inclined, vote early and vote often. Okay, so we're going to take a little different spin on this than we've done with other things. I've basically asked each of them to sort of talk briefly about sort of the third agent that they might add to an ADT ARPI backbone. The graphics got a little screwed up there. I don't remember the order, but Michael's going to do lutetium. We just got through with that. Neeraj will talk about PARP inhibition, Tanya docetaxel, Chris AKT inhibition, and then Chuck's going to say that we really shouldn't be giving a third agent to anybody. That's what the first do no harm is. So if they'll each sort of just present, I think we have 2 or 3 slides, just sort of what's the state of the field, what's the data supporting, et cetera, and then we'll discuss and debate a little bit. And then at the end, actually, we have cases. So we have sort of, it's a fabricated case that I've changed the features throughout the case and stuff. And then we'll talk about, actually, Petros, see those whiteboards? Did you bring them up? Just put them on the side of the stage. We're going to present a case, have each of them sort of write down what they do for that particular patient, and then we'll talk about that.
Oh, wow.
Yes, this is high technology, high technology.
We're passing around?
Just as a place to start, yeah, pass them out if you could. Just as a place to start, this is from the APCCC, our friend and colleague Silke Gillison, who we will one day get to Nashville. Runs this great conference in Lugano, Switzerland every other year about sort of the state of prostate cancer and consensus across various aspects. And I think, I'm not going to go through this, but I think it just lays out the ADT ARPI backbone for all patients except perhaps frail or limited life expectancy. And then based on timing of disease, synchronous versus metachronous, and volume of disease, i.e. number of bone mets, what's the intensification approach? And you can see sort of the consensus based on the number in favor. So I think this was in May. So this is before a lot of the data we heard about with PSMA addition and amplitude and other things that we'll talk about, but sort of the state of the field at that time. And what we're going to talk about is, all right, now if we want to add more things to it, how do we do that? All right, if you see your picture on a slide, then that's your cue to start talking.
So I remember when Charted first came out, and we were really shocked that using docetaxel early versus later made such a huge impact in survival, right? So we know that docetaxel, as much as we don't love to use chemotherapy in prostate cancer, really can have some profound effects. And we probably all still have patients in our clinic who got that regimen and are in remission still on their ADT, right? But of course, the AR pathway inhibitors also provide profound advantages in the metastatic hormone-sensitive setting. And so it came out through the doublet and triplet sort of experience that volume of disease and synchronous versus metachronous actually do make a big difference. So this is a meta-analysis of these trials where you can see that for high volume, the triplets come out on top, whereas for low volume, probably the doublet is perfectly adequate. Can we go to the next slide?
Yeah. Just say when you want to go.
But of course, wouldn't we rather use molecular features, biology, and not only the clinical features? And so it was really exciting last year at ESMO to see the work using Decipher in the Charted and Stampede data sets. And essentially, if you have a high or a low Decipher score, you benefit from the abiraterone. But if you have a low Decipher score, you didn't benefit from docetaxel. So really, could we use Decipher as a way to pick who needs the triplet, who needs the docetaxel? And then moving on to the next, I'm so apologetic that we don't have the authors on this. Emily Grist is the first author, and Gert Attard is the senior author. This is a beautiful, beautiful, deep scientific paper looking at a number of different signatures, including PAM50, luminal basal, AR, P10, Decipher in the data set from Charted. And one of the things that stood out was P10 deletion seemed to also be very predictive for who benefits from docetaxel. And that's what these curves are showing, that if you have active P10, maybe you don't benefit as much from the docetaxel.
So let's pause there. I'll ask others to comment. And my specific question would be, are we ready? How do we use these in practice? Do we need prospective data? Where does Decipher or P10 or whatever biomarker go from here? Chuck, do you want to start?
Well, I think it just also begins to put tumor biology ahead of counting lesions on a bone scan as a major driver of decision making, which I think is a good thing. This won't be the end of such tests. Are we ready to make all of our decisions based on this? No. Do we need a prospective trial? I think we have better places to put our resources. In terms of validating docetaxel by Decipher.
So you wouldn't do a prospective trial based on this?
In hormone-sensitive prostate cancer, are we gonna get that done? This would be pragmatic about it.
So if you don't do that prospective trial, I guess, how do you move it forward? Maybe that would be.
Yeah, some data, it's a good question. So some data comes out and it basically is, this is why we have studies like Charted and Stampede, which have been so influential, is because the studies were done, samples were collected, and we continue to study them. So this is as much a testament to the Decipher predictability as it is to our ability to do these big hard studies and keep pounding away at the data. So I'm just going to make that point. But the other thing is that Decipher itself is an iterating test. And there are new versions coming out, and they keep integrating new biology, et cetera, et cetera. So we may see further and further analyses, outcomes of this particular data set with newer iterations of the Decipher test. And, I just am thinking realistically here. Are we going to really do another mHSPC study where we're going to use Decipher, where we're going to integrate a new marker? As much as we'd love to do it, I just don't think it's going to happen.
Fair enough. Other comments?
I'll weigh in on that. So the challenge is, and for the record, Tom, thanks for the microphone. The question is, this is ADT docetaxel versus ADT. Testosterone suppression doesn't have the ARPI question. So hopefully by ASCO next year, annual meeting, we'll actually look at ADT dosi Enza versus ADT Enza to answer the question.
Yeah.
Now the challenge is that for some reason, patients got docetaxel on enzalutamide based on physician intuition. And it turns out physicians are really good at choosing who does poorly versus not. And the patients who got docetaxel had a poor prognosis in ENZAMET. So hopefully we'll be able to account for that in the biomarker analysis and ask, does this hold up in the ADT-ARPI versus ADT-ARPI docetaxel setting? So at this stage, it's great, but your point is absolutely correct. There is a lot of love between the cooperative groups and getting together between Chartered, Stampede, ENZAMET to answer these questions, because we can do this as a cooperative group and actually dig deep. So I just want to shout out to the cooperative groups. We can ask bigger questions beyond industry-based studies because we have a longer time frame.
These are our tax dollars at work, by the way. Honestly, seriously, cooperative group studies, NIH, look at where we are. We're learning so much from them.
I think Chuck should be a politician, don't you? He's really very, very poised. Michael.
Yeah, I just want to separate the effort to create better prognostic criteria versus those that are treatment selection criteria. So P10, for example, we know can segregate well-performing from poorly performing characteristics, but that overlaps with a number of other different biomarkers. And so the real challenge there is sorting out which is really the driving biomarker and which are the others that follow downstream from that. But for something like P10, where you could use it as treatment selection criteria for an actionable alteration that leads to a better outcome clinically, the same thing with PARP or PSMA or whatever, those represent really remarkable opportunities to intervene in a patient's otherwise natural history. And those, of course, can be tested because you can just, if it's druggable, you give the drug or you don't. What Chuck, I think, is alluding to is just developing and seeing which are the dominant prognostic factors. I'm not even sure that that's something that we would invest money in, as Chuck was saying, to do prospectively. But this is a different effort. This leads to an actual, a drug, a trial, and a patient who may do better as a result of being identified with the marker.
Niraj?
My approach, you said, what is your take on these data? I like to start every patient on ADT plus ARPI and then build up from there. If we can do that for most of our patients, that will be a big win. Even now, 30% of our patients are not getting ADT plus ARPI. So all these tests are great, studies are fantastic, but I think we need to implement them in our real-world patient population.
So just to summarize, we'll move on, is docetaxel obviously a clearly established role, right now selected by timing and volume of mets, but hopefully better biomarkers moving forward, but we're not quite there to implement them in practice. Okay, good. I see shaking heads, so I like that. All right, Niraj, you're up.
So this is the amplitude trial data presented by Gert Attard a few months ago and then just published. So this is mHSPC setting. Patients had to have these predefined, pre-specified HRR mutations. So you can see here BRCA1, BRCA2, BRIP1, CDK12, and so on. And key eligibility criteria were they had to have hormone-sensitive disease, hormone-naive disease, and they were not allowed to have any PARP inhibitor or chemo or any of that prior to a diagnosis, but they were allowed to get chemotherapy in the metastatic hormone-sensitive prostate cancer. This was a different trial from what we have just discussed, that chemotherapy was allowed. Despite the fact that 80% of these patients had high-volume disease, 90% of these patients had de novo disease, only 16% of these patients actually received docetaxel chemotherapy, thus reflecting that chemotherapy use is very low in the real-world setting or even in trial setting. Now, coming to the randomized portion, patients were randomized to ADT plus abiraterone versus ADT plus abiraterone plus niraparib. Primary endpoint was radiographic progression-free survival. It was met. There was a statistically significant improvement in BRCA1 and BRCA2 patient population. You can see here the HR is 0.52, 50% reduction in risk of progression or death in those patients who had BRCA1 and BRCA2 mutations. Please note that ATM positive patients were not included in this trial. So BRCA1 and BRCA2 mutation positive patients were about 50% of total patients in this trial. I would also like to bring your attention to the control arm, PFS, 26 months. We expect 39, 40 months in these patients. So that it tells us that these patients have poor prognosis and they need something better. If you look at all HRR mutation patients, it was 0.63 as far as hazard ratio is concerned, and there's a 40% reduction in risk of progression or death. If you look at the table on the right side, upper right corner, that shows you the breakdown of RPFS benefit by individual gene types. And my take on this is trial is not powered to look for these individual gene subsets. So I look at them, and this is for your information. Next slide. Do we have a slide again?
We do. We have one more.
Yeah. So this is a secondary endpoint, overall survival. Very important secondary endpoint, is not mature yet. If you look at the side effects, no new signals from the efficacy perspective. Anemia is common side effect with PARP inhibitors, and we know, and many other anti-cancer drugs, and we know that anemia happens in first 3-4 months, and timely reduction of dose of these patients who develop grade 3 for anemia can allow these patients to receive PARP inhibitors for a long time. So timely identification of these side effects. Cardiovascular side effect is unique for niraparib. Hypertension is quite common, but this is also common with abiraterone. So timely recognition of hypertension and treatment is necessary. So what is my take on the amplitude trial? Abiraterone plus niraparib should be considered as a standard of care for patients with mHSPC with BRCA1 and BRCA2 mutations, and an option for patients with mHSPC with HRR mutations. For these patients who are starting this treatment, I monitor them very closely for blood pressure and liver function tests for abiraterone and CBC for PARP inhibitor. And ultimately, timely symptomatic management is the key to allow these patients to continue treatment for a long time.
Thanks, Niraj. All right. Comments on the data, questions, nuances? it's available tomorrow using it, and who are you using it in, Michael?
I think it's a great study. First of all, it's a contemporary control arm of ADT and an ARPI. Second, the trial was selected for the patients most likely to benefit, and they did the sub-analysis to see within that group of patients who is most likely, of the most likely to benefit. And I think that if most people seeing this data had a patient walk in with a BRCA mutation to their clinic, Niraj was being very magnanimous and saying, well, it should be considered, but who among us would not give that therapy?
For the BRCA
Yeah.
mutant, yep.
It's the least controversial of all the mHSPC studies.
That's right, yeah. Chris, did you want to say something?
Yeah, I curmudgeon. My name is Chris. Number one, this didn't allow docetaxel as a front-loading therapy.
No, it did allow patients could get
But
docetaxel.
it didn't get it.
So I guess that's a question. It's really high risk, but only 16% got it. Is that just because people don't want it?
Well, I think it's because you had a biomarker, right? You knew this patient had HRR and was going to go on to a trial where they might get a highly effective therapy. I don't think this reflects how we would treat a non-HRR or especially non-BRCA
I buy that.
high volume de novo metastatic patient.
And so the other thing, I'm just pushing the issues. I'm pushing buttons. It's Saturday morning, as I do. So the HRR mutant, that includes the BRCA patients in it. What is the data without the BRCA patients in that group?
Yeah, we don't know. They didn't present the HR
No,
not
what-
BRCA, or did
what-
they?
what-
I don't have it on the slide.
Why don't they-
Okay.
HR not and take out the BRCA. Right,
they
it would
not
be
do that?
higher.
Why did they not do that?
I just want to make a comment on docetaxel with due respect to fantastic work Chris has done for the field. This patient population had 90%. 90% of these had de novo disease. 80% of these patients had high volume disease. Docetaxel was allowed for these patients prior to enrollment on the trial, and 16% of these patients received docetaxel. These are trial-eligible patients, ECOG performance status 0-1. And it is very consistent with real-world data that less than 10% of patients in the US receive docetaxel chemotherapy in the mHSPC setting.
I mean, I think Tanya's point's a good one, though. If I'm the doc, I might be like, oh, I got this great targeted therapy. I don't give chemo. I don't, even if they need it by other criteria. I don't know that's the case.
But there's a 50% chance they won't get it.
Fair enough, but we don't know why. I think it's a good hypothesis.
I'm just saying
That's all I'm
that the data keeps coming out. Docetaxel, the old dog, still works. I'm not a docetaxel defender. I'm a data defender. And that's what I'm going to say right now. But we talk down docetaxel.
I don't think we're not talking down docetaxel.
No, as patient, when we talk about there's chemophobia in the world, and we do not talk it up. We talk it down.
Michael, last word on this. We're going to have to move on for time, unless you want to.
We don't know that docetaxel would have been appropriate in addition to an AAP in this patient population or any other. It's never been shown. So to criticize this trial because it doesn't use docetaxel is silly.
I agree.
Silly. It's not silly. It's the question.
Blah, 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 docetaxel.
I mean,
It is a question, actually. So Arnes actually has data from Chartered suggesting the patients who did have a germline BRCA mutation, and we're trying to follow up on this, did actually worse, and they didn't benefit from docetaxel. There's actually biological reason why they may actually benefit from docetaxel. I'm just saying there is an alternative agent. If you can't get this, that may be benefit, and we need to ask the question.
But this trial wasn't set to answer that question.
No, it's not sent to ask the question. It's set to ask the question about the new drug, the new therapy, the expensive one.
The control arm is not a new drug.
No, but I'm just saying that.
comment to Chuck. I'm going to make a comment.
I think, what am I, the first do no harm guy for this panel?
Yes. You're the elder statesman.
Yeah, the elder statesman, right. And so one of the questions that we should be asking of this trial is, does this help us with the ARPI plus PARP question at all? And are there BRCA patients, for example, who are so exquisitely sensitive to PARP inhibition that maybe the abiraterone and et cetera is something that we could consider pulling out? So I'm just taking the. I didn't mean to insult.
We don't have a dog in the fight, but yeah.
But what I'm saying is that it does it suggest to some that there's an opportunity to use PARP inhibitors in a de-escalation strategy in hormone sensitive.
De-escalation. I love it. So last comment from me, and then we're going to move on in time, is I think what we're bumping up against is we have a lot of new third agents we could give. That's what this whole session's about. And we can't give them all at one time, right? So you're going to have to select whatever your criteria are. And I think as we get to the cases, I've made some that are intentionally doing that. All right, Michael, we just got done with the session, but maybe like a quick one-sentence summary, and then some who weren't on that panel can comment.
Sure thing. Quick one-sentence summary is we already have approval of the use of lutetium across the spectrum of metastatic CRPC. And so this was the first randomized study to look at lutetium for CSPC. Did I say CRPC before? So we have approval on CRPC. This was the first in CSPC. The trial was ADT, the ARPI of physician's choice, plus or minus lutetium. They got 6 doses every 6 weeks per convention. The primary endpoint was RPFS, and there was a crossover, so OS was a secondary endpoint. RPFS looked like it was positive with a hazard ratio of 0.72 in favor of the lutetium triplet. OS, which is quite immature, revealed a preliminary hazard ratio of 0.84. For neither of the arms do we have a median overall survival to report. That's in both cases, actually, for RPF as well. So the data are early. And from a tox standpoint, there were more adverse events in the lutetium-containing arm, particularly in relationship to xerostomia, and there wasn't a statistically significant difference in quality of life between the two arms.
We just lost 10 minutes on our timer somehow. Comments on the data, Chuck, you weren't in the other session on the panel. So.
Yeah, so I mean, getting back, this obviously offers an opportunity for integrating a new therapy into mHSPC, which is great. We'll see where we go with longer-term outcome and approvals and things like that. There's been a lot of debate that I can't really add to on the potential toxicity, et cetera, of this approach in earlier stage disease. I would ask the question of whether we're going to see a tox signal from a late effect tox signal from lutetium, which is different from docetaxel. For example, the docetaxel toxicity stops at the end of docetaxel pretty much, and the quality of life data suggested that you pay a cost in quality of life and you get it back. We don't know that quite so yet. We don't know that yet with lutetium, and I wonder, will there be problems with patients who are surviving 4, 5, 6 years?
Yeah, fair enough.
Platelets and things like that. So we'll wait and see.
Niraj, any comment?
Yeah, so first of all, congratulations to the Alliance team and the PSM Edition team. This took, I think, 7 years to complete this trial, and I'd love to see a positive trial in prostate cancer and have this option in the clinic. Now, next step is to learn how to do it, how many doses we should give, and how to manage toxicities long term. But I do want to make a comment from the previous session. We were talking about CCTG PR21 200-patient trial, phase 2 trial comparing docetaxel with lutetium, and docetaxel was superior in a 200-patient trial, and then PSMA4 trial, lutetium was superior to ARPI. And what is the comparison? What is better? What is worse? And my take on this is very different patient population. If you look at the overall survival of patients in the lutetium therapy arm in the phase 2 trial, that was 14 months. If you look at the overall survival of PSMA4 patient in the lutetium arm, that's 24 months. That's 10 months difference. These are very different patient population. So my personal take is both are great therapy, and docetaxel is a viable treatment, which we already know.
All right, I'm going to thank you for that comment.
Can I just say one thing about the docetaxel?
Chuck just said, sure.
The issue that keeps coming up and that Chris aptly raised is the use of docetaxel, which is the implicit control arm that has never been tested in these triplets.
Yeah.
But I would just give a plug to the ASPIRE trial, which is now approved by an opening through the cooperative groups, which is ADT, ARPI, plus or minus docetaxel. And there's also a SWOG study that is also a multi-group study that is looking at intensification for poor responders with docetaxel for those who don't completely respond to ADT and an ARPI. So I do think that Chris's concerns will actually come into the contemporary era through trials that are up and running. And I'm sure that those trials aren't going to meet whatever level of perfection that some are demanding, but those are the trials that we'll have, and congratulations for the people for doing the right study to address Chris's concerns.
Chris, we're going to move.
Love the cooperative groups.
We're gonna move to AKT inhibition.
Tax dollars at work.
Yeah, we're going to move to AKT inhibition. If you just want to give us a summary.
So AKT inhibition, it's a great idea. It's a biologic therapy. We have a target. The problem is we don't know the right target. So here is the top showing eye potential, abiraterone plus or minus apatosertib in patients with first-line castration-resistant prostate cancer. RPFS benefit, 0.77, OS, nothing. Disappointing. It's part of the, from the beginning, my day in the sun faded. Now, sorry, reminiscing. No, that's not about me. But you look now at Capitello, we look there, the IHC greater than 90%, RPFS benefit, no clear OS benefit. Now, if you, about 6,000 patients were screened to get on the study by IHC, and if you go down to 100% P10 negativity, you get a stronger signal. Now, the question is there a better biomarker? And the answer is, well, when we looked at a P10 loss in the eye potential study, yes, there was an OS benefit. If you look at the whole pathway, AKT mutation, PIK3C mutation, P10 loss, the signal gets stronger. So I think the study was not the best study because it didn't have the best biomarker. Yes, P10 IHC is a lot easier than an NGS. Why they didn't push forward with the NGS is unclear to me, because then you now look at capivasertib with fulvestrant in a very similar disease, breast cancer ER-driven, estrogen receptor-driven disease. They did use the NGS and look at that whopping overall survival of 0.69.
So let me ask sort of you in the panel, is there any future for, given everything we're talking about and all the activity, et cetera, is there any future for AKT inhibition in prostate cancer?
Can I just point out the toxicity profile?
Please.
Abiraterone, prednisone, and AKT inhibition did result in a lot of hyperglycemic hyperosmolar and some deaths. This is not without its toxicity profile. The death rate from this is greater than the death rate from docetaxel. Oh, sorry, I said that word again.
Anybody else comments? I mean, it seems to me.
I think your question, is there a future? Yes, there is. I mean, we have, as has been said a few times now, there's a duality of issues here, two variables, the drug and the test. And we know that that P10 loss is a big driver of morbidity and mortality in prostate cancer. So it is a very appropriate target. And we now have a signal on a drug that with a positive study. That's a good thing. This is the beginning of a conversation.
Okay.
That started 30 years ago, but now it's like it's a beginning of a clinically validated conversation.
Fair enough.
But I would say, given the negative trial in CRPC, and given that we may learn that the same biomarker actually predicts for benefit from some of the other agents in the first-line setting, it's a little unclear to me how much of a role there will be. I mean, I hope this is a positive trial. Of course, I want it to translate into practice, but as we're learning more about this particular biomarker, it may not only apply to this drug.
What's drug might apply to? Do you infer? Docetaxel?
There's also the apatosertib and the capivasertib studies are different populations. So different drugs, different biomarker, different population. To answer your question, is there a future? There is a future, but we have to use the right triad there in selecting where to pursue the pathway.
Agree.
So how much time? 20 seconds? 15? Okay. So anytime I see a positive phase 3 trial, it makes me very happy. I know the years of work which has gone into this. So yes, there is a future. If you look at the cutoff, P10 loss by IHC cutoff, 90% was the predefined. But if you look at the 100% cutoff, the magnitude of difference for benefit favoring capivasertib goes up in the mHSPC setting. So ultimately, I hope we have this option available, and we can decide in the clinic who is the right candidate for this drug?
That's a really good point. I mean, the positive trials, hopefully we'll get a drug out there available for us to use in appropriate settings. And it's our job as thought leaders, as academics, as researchers to optimize the use over time. And I think we need to, embrace that a little bit more.
I'm hitting this more optimism than I thought. So I'm hearing like not quite there maybe, but optimism for the future. Fair enough? All right. Chuck's going to take us home on the do no harm de-escalation.
Yeah, so I get to present a case as a patient of mine, 58-year-old gentleman who had, in 2022, had a Gleason 7, and he underwent brachytherapy for that. He had a Decipher score done back then, which was 0.66. So he then had a rising PSA, which was watched for a while. And then when I met him last fall, when I started at MSK, he had the rising PSAs done, and he had this October of 2024 gallium PSMA PET scan, which you're seeing here. And there were 4 lesions. At this time, his PSA was 14, and 4 lesions. And what struck me was that there were 2 extremely bright lesions, T8 and T10, with the SUVs of 42 and 57, and 2 that were less bright. None of them were symptomatic. This was a patient now with metachronous oligometastatic prostate cancer. So I started him on relugolix and darolutamide, and his PSA promptly dropped to 0. And then we completed SBRT to the 4 metastases in February. PSA has remained 0. You can flip this, move the slide. And so it's for me, a very thought-provoking case because this is a young guy with a lot of life ahead of him. We now have a lot of clinical trial to support various therapy choices in this patient. And we have some gaps in our knowledge for patients such as this. But he does sort of follow into the box here, red box, metachronous or recurrent, where the NCCN guidelines recommend doublet therapy, which could be considered in the high volume or triplet for the high volume, and doublet therapy for the low volume. It does not quite answer the question of who should get SBRT and who should not. Go on to the next slide. And so I bring this case up for a few reasons, of course, that we'll discuss. But one of the things, and I guess I'm the what am I, the
Do no harm.
do no harm, but I'm also the the glass is half full kind of guy here today, because many of our patients, if not most of our patients, and when we look at all of these phase 3 trials, we'll have deep and durable responses. Again, when we consider PSA as the marker, which may not be the end of the story there, and that patients who have deep and durable PSA responses that's associated with a favorable long-term OS. So the box, the columns, the bar graph on the far upper right is from the darolutamide experience, and demonstrating that at any point during therapy, about 2/3 of patients will experience a PSA of 0 or of undetectable. And the bottom graph are basically the outcomes based on who has a low undetectable PSA versus not. And I think all of us are experienced clinicians enough to know that a good response by PSA early on, as this patient experienced, is a favorable thing. And so now we've been talking about all these trials of adding this drug, adding docetaxel, et cetera, and the implication of all these results is that we're going to continue to treat patients forever with these drugs, or at least I should say until the particular therapy fails. But now go on to the next slide. Here I am with this young, healthy, vigorous patient whose PSA dropped promptly to 0. We've completed the SBRT. And I told him from day one that I plan to give him a finite duration of therapy. I couldn't predict the future. Of course, I can't predict the future. But this, to me, just seemed like a case where if we go at it aggressively and we ablate the treatments that we can see, this is a patient where we can drive his tumor burden to 0. It's about as good a case as we're going to get. So when I bring up the issue where I was assigned the notion of first do no harm, I guess I would say first do a little bit of harm and then back off on your harm or back off on your therapy. And that's the point I'm trying to make is, can we be having more and more of these conversations about even curing metastatic prostate cancer or at least driving a situation to having a long-term treatment-free interval? And of course, I'm not the only one out there making this case.
Excellent, Chuck. Thank you. Tanya?
So I just want to point out that when NCCN makes that recommendation for doublet, it's not based on PET-detected metastasis, right? It's using conventional imaging. And I think we need to figure out. I mean, obviously, metastasis is metastasis, but when we are seeing it so early, that really is a different patient than when we're seeing on conventional imaging. Second, in terms of do no harm, I do worry about radiating everything we see on a PET scan when we know there can be false positives. And I think we have the luxury, being at academic institutions, that we have tumor boards and we look at these with our radiation oncologists and our nuclear medicine physicians, and we make a nuanced judgment about what to radiate. But doing no harm also includes not radiating things that shouldn't be radiated.
So doing more harm also includes giving 7 years of ADT to a patient who only might need 18 months, right? And so
I completely agree with your practice of backing off.
What duration, Mr. Do a Little Harm, what duration of therapy?
Dr. Doolittle.
Doctor, sorry. Dr. Doolittle. What duration of hormone therapy would you give? Do you have a set standard, or you're kind of winging?
So I have to see him in April, and I sort of planted the seed at 18 months of treatment.
18 months. Okay, arbitrary but reasonable.
So I'd like to highlight a beautiful paper. David Einstein is here, and then Ravi Gadden was the senior author in JCO on defining PSA recurrence with PSMA PET positive disease, conventional scan negative disease. And they have proposed a new terminology, PSMA PET positive BCR and PSMA PET positive negative BCR. And I love that, David. So wanted to give the shout out. And in this case, this is a PSMA PET positive BCR, not to me, mHSPC. I mean, we can define it, mHSPC.
Early, yeah.
And I agree with Chuck that this patient requires definitive duration of ADT plus ARPI, not indefinite.
Can I weigh in there? I suspect looking at those PSMA PET images, there was probably sclerotic lesions that would make him conventional positive.
Right.
So, but not always, you're right. EMBARK study with the overall survival would suggest that this patient is not too dissimilar to the metacritous low volume on conventional imaging with an overall survival. Presto earlier yet with median PSA of 1.0. But I'm going to go and I'm going to say this. Wait for it. Dr. Doolittle, Dr. Doolittle.
Dr. Doolittle. Harm.
Dr. Docetaxel.
What?
Yeah, Docetaxel.
All right, I want to get to the cases.
He should not get docetaxel.
I just put out this poll about will have the biggest clinical impact on the greatest number of patients. Don't criticize the question, but that's what I came up with. And it was sort of interesting that docetaxel and lutetium, sort of were clear winners. AKT, maybe not surprising given the limitations. I don't know, Michael, if you had a comment on this, and obviously PARP's at a disadvantage because it's, either BRCA or even at HRR, right? So I think that's probably why that didn't score as well. Let's get on to the cases. You all have little whiteboards, so as soon as I finish the case, you're gonna write down what you would do. All the relevant data is in the chart. The image is representative, so if I say there's 3 bone mets and you think there's 4 in the image, they were just pulled off the web. These are made up cases for purposes, so don't pay attention to the image too much. It's just there so I have something to show on the right side. 68-year-old ECOG1, radiation and short course hormones a while ago, had an appropriate nadir but then lost to follow-up, shows up with a PSA of 126 and multifocal bone mets on a bone scan, no visceral disease on CT, does not have a PSMA PET at this time, has an ATM mutation, and PTEN status is unknown.
Is he symptomatic?
Patient is mildly symptomatic. That's what the ECOG1 is meant
What is
to.
the testosterone level?
It's normal.
Is hormone sensitive or CRPC?
Hormone sensitive.
Hormone, okay.
Yeah.
Writing down what we would do.
What drug or drugs would you give this patient? Just high level. And then I'll ask you to reveal it and give sort of a short rationale. Chuck, I'm going to start with you. Unless you want me to end with you, because you seem...
I'm ready.
Yeah, no, take your time.
I'm done with you.
I'm ready whenever you are.
I'm going to do 8. Do I review?
Yeah, sure.
Oh, yeah. I'm going to do 80. I'm going to do ADT plus an ARPI, and the reason I'm not adding docetaxel here is it's 5 years. It's metachronous disease. He was lost to follow-up. This could suggest a slightly slower biology than somebody who had a normal PSA 2 years ago and shows up in the ER with bone
Yeah,
mets.
fair enough. Niraj.
ADT plus ARPI, I have nothing else to add to what Chuck said.
Awesome.
I would at least discuss DOSI with him, even though it's metacronous and
Because of the volume of disease.
because of the volume. He's young. He has a PSA 126. Okay. I would consider intensification.
Any reason to do a PSMA PET?
No, actually.
Okay. You wouldn't do it because you want to give him lutetium.
Right now, I don't think the data are mature enough, in addition, for me to add lutetium, so I would not do it right now.
Fair enough. Chris? Docetaxel.
Yuck. Metacronous high volume is a very heterogeneous disease, so I agree 100%. Not all metacronous, but the point estimate of 0.7 in the looks similar. So if he presented with a bone scan like that, I would be more inclined. If he had 5 metastases and he presented the way you described, I would not give it, but I would probably lean towards yes. But there are patients with metacronous high volume who are lean towards no.
Does the ATM figure in? Nobody's met. Oh, I guess Tanya hasn't waited.
Tanya? Who has
So-
the neatest handwriting, by the way, by far, by far.
I would definitely use doublet. I would talk about docetaxel. Makes me a little nervous that he disappeared. I would want to make sure he's going to follow through.
Point.
But I would feel perfectly comfortable putting him on a clinical trial. I'm being told that we cannot use that option, because of course all of us in this room probably would. But just to say I'm not that dogmatic, I would talk about docetaxel. He's symptomatic, high burden, but I would be open to a novel triplet.
So
I should have taken clinical
just a
trial
very-
off the table.
Just a very quick note, the PSA nadir point is very important here. And he had a very nice PSA nadir with the first time when he got the ADT. And that's a very good marker, I think, for me.
For being hormone sensitive.
Yeah.
Yep, fair enough. And low tox Yep, fair enough. All right. 68-year-old guy now, ECOG 0, has the same sort of history of somewhat remote radiation and hormones inappropriate nadir. Excuse me. This PSA now is lower, it's 12.5, has more oligometastatic disease, 4 bone mets on a bone scan, no visceral disease. You see rib, 2 spine, and a pelvis. That's what the images are supposed to show. These are all PSMA avid, so I guess not terribly dissimilar from your case, Chuck, maybe a little older. Has a CHEK2 mutation and unknown PTEN status. We should add some music while they were writing next year. Write that down.
And this is de novo, isn't it?
Prior radiation.
Yeah.
Yeah, how long
Basically
ago?
the same case, but the
5
recurrence
years,
is,
5 years ago. Yep.
the recurrence is more oligometastatic.
Yeah, that's
is sort
I'm
of
reading
what
it
getting at.
properly now.
Very similar to my case.
Yeah.
Yeah, similar to Chuck's case, so I think we know.
But do what I did.
Metacronous may be low volume.
All right. I'm going to start over at Tanya this time. Go ahead.
So I would do what Chuck did for his case and give doublet for a defined course and
What's your,
SVRT.
how long would you give doublet?
I'd say a year.
Just a year. Okay. Chris?
Doublet SBRT 2 years.
You'd give 2 years. Okay. Michael?
Doublet SBRT. I'm not going to commit to years.
How do you decide?
That's the problem.
Okay.
That's
I
the issue.
give 2 years completely arbitrarily just so that I have a number, and some patients don't make it, but I don't.
I kind of extrapolate from the 36-month versus 18-month ADT study in radiation-treated patients from years ago,
Okay.
suggesting that 18 months is much better quality of life, not as roughly
Yeah.
equivalent. It's an
Fair
extrapolation.
enough. Niraj?
So this is PSMA PET positive BCR. So I'll give ADT plus ARPI plus SBRT and a definitive duration of therapy, about 2 years.
About 2 years. Okay. Chuck?
Same as everybody else. I drew SBRT discussion because apparently that's what we'll talk about in the last case, which we can have dead discussion. But
Okay.
I don't know where the pelvic lymph nodes are relative to the prior radiation, so that's why it's not a
Okay.
guarantee.
I might add, just in relation to Tanya's point that she made before, that if this patient had a lesion that was just PSMA positive, I would absolutely irradiate it. In your example, it was 4 PSMA positive, 4 positive on conventional imaging. So everything matched up. But we know from Oriole and from Empire One that if you use PSMA PET in the guidance of your treatment, the patient has a better outcome.
I was just alluding to ribs, which we know can be false positives, right? And you've probably seen some scans where there's like an indeterminate, right? So
Right.
Yeah,
I agree. You don't have to have a CT correlate or MRI correlate, but you want to be confident that what you're treating is disease.
We have a nuclear medicine doc in our tumor boards, which is super helpful because I didn't realize all the nuances of not having a correlate. And I assumed positive was positive, but clearly it's not the case. All right, we're making great progress. Younger guy, 58-year-old, ECOG 1, no prior treatment, comes in with the PSA of 412, a lot of bone mets on scan, also has liver mets on CT, assume it's all biopsy proven, multiple PSMA avid lesions, has P53 and RB and PTEN altered by NGS. Yes, sorry, we don't have things to wipe off the answers.
The back of the pen is an eraser.
Oh, I dropped it.
It's a low budget operation.
I'm always mentoring.
All right, who wants to start? Anybody? Neeraj, you ready?
Yeah. This is rather straightforward. P53, RB1 loss. This patient is destined to have, at least not destined, but very likely to have neuroendocrine differentiation down the line. So this is high volume metastatic prostate cancer, de novo, young man. I will go with ATT plus ARPI plus docetaxel.
Triplet? Okay. Anybody different? Oh, Chuck.
I'm doing a quadruplet here. And this is something that
I thought you heard Dr.
Yes.
Doolittle.
huh?
Yeah.
No,
This is This is Dr. Dumont.
this is Dr. Demore and Dr. Doolittle, but
He's the viewer as well.
again, don't ask me for phase 3 data, but I've treated a number of these patients. These patients, I had one who just died within a year of diagnosis with this exact profile, and we've attempted to integrate carboplatin with cabazitaxel. We did a hormone-sensitive study in that. Love to do a phase 3, but we can't get that going. So I think this is one where he's going to be a neuroendocrine patient in about 9 months.
Yeah.
and we want to try to.
And I was sticking to the approved therapies right now, but I agree with you.
Okay.
Yeah.
So intense therapy, chemo-based, maybe doublet chemo. Love it. I think we have maybe one or two more. 68-year-old man, ECOG 0. This is also somebody who had prior radiation. PSA is 74. Multifocal bone disease. Equivocal liver lesions on CT. You see the PSMA PET there. Multiple PSMA avid bone and lymph node lesions, high SUV. This patient has a BRCA2 mutation and is PTEN deleted. So,
Are we
often does it
projecting
happen
to
where you can both?
2026 when we might have some approvals
sure,
that we don't have
assume you
today?
have all the drugs. There's no reimbursement limitations. This is just, yeah. I don't want that to limit your answer.
Pretty straightforward, actually.
Well, I think that this gets at, this is a good question. I like this because
Thank you.
you have to decide between Capitello and amplitude.
And your decision is?
Oh, my decision is niraparib, ATT plus abiraterone plus niraparib. Because of
So
BRCA2.
the BRCA drives, does the BRCA drives everyone to use PARP? Tanya, I can see your
I think
answers. Yeah.
Chris's point, though, is interesting about docetaxel. Says that was allowed in amplitude.
What did you say?
Okay, so maybe Trish, you give docetaxel
Yeah,
first.
that to give you time to fight the insurance companies.
Oh yeah.
Yeah. Right, okay.
That's a bad scan. You can't wait.
So you'd start with chemo, and then when chemo's done, give PARP.
Yeah.
Is that right?
But I like that.
That's very appropriate. The only concern, and as I was a part of the amplitude trial, one reason we did not see very high use of docetaxel chemotherapy was the concern that if you give chemo, myelosuppression may make them less eligible for PARP inhibitor down the line. But again, there are no data in this regard.
Yeah.
And I personally think BRCA2 is such a dominant player in this case that if I can get PARP inhibitor,
That trumps everything when you have BRCA.
Totally agree.
Yeah.
Yeah, okay.
I agree
And
with
I guess the question is, how often do we actually see BRCA2 plus PTEN deletion?
It's rare. It's rare.
It's all made up, Chuck. It's all made up. That's
I
why.
know I know what you were trying to do, but
yeah, I was
I
just-
think
Because it
that's
could
two
be cancer
drivers.
I was trying to put you
Yeah,
in the
yeah.
box there. Okay.
We're smarter than
They're
that.
almost mutually exclusive.
We are out of time. I'd like to thank the panel for your excellent participation. Thank you.